we're going to talk about Chapter 5, which is Pediatric Drug Issues, Absorption, Pharmacokinetics, and Pharmacodynamics, and as well as certain things that we should do as a nurse when we're giving medications to children. So anything highlighted in red, really make sure you pay attention to those and make note of it. You can go along in the textbook if you'd like, or not. All right, so let's get started here. Don't you like the background of this one? I think it's really cute. Makes me more cheerful to want to record about this, right? Okay, so there is much limited research on pediatrics. So why do you think that's so? Well, if you had a child, would you want your child to be in a new drug trial? Perhaps if your child had cancer, terminal cancer, and you're like, you're looking for some hope. But what about with just other types of medications? A lot of parents are reluctant to put their kids in research, and I don't blame them. So up until 2012, really, there was a lot of marketing over the counter, such as your cough medicines and things like that, that really says it was indicated for kids when really they've really not been studied on kids. So then an act came out 2012 that said that, you know what, we need to really, if we're going to advertise for kids, we really need to do research on kids. So drugs for children have to be tested on children. So basically it's like false advertising. Right now, information is usually brought forth by smaller adult studies to say, okay, this will probably work in a pediatric child. So when you go to the pharmacy, kind of take a look to see what's out there. It's very interesting. Also, you know, we talked about the risk. You always have to get informed consents and tell the risk. So again, if you're telling a parent the risk that your child can have from doing that, you're going to be more reluctant. So drug companies also are worried about liability. So they're not putting a lot of money into that area for pediatric drug research. So now we're going to talk about the pharmacokinetics. So you should already remember one of the couple other last slide sets where we talked about what pharmacokinetics was. So absorption, distribution, metabolism, and how it's excreted. So let's talk about kids. Kids are much different than adults in how they absorb. Their bodies are more immature and they're still developing versus adults. So there are a lot of other factors to take into consideration. Weight is really important on how a drug is distributed. So whether they're an adult or a child, you have to think about weight. And remember, the child's still growing. So when we prescribe amoxicillin, we need to use the weight and determine the dose in that way, no matter what age they are, because they just continue to grow and grow and grow. And so it's weight dependent. Weight's always in kilograms, so please remember that. Those are the influencing factors. The route of administration, we have to remember that gastric acidity and gastric emptying, how motility, how the perhaps food or formula or breast milk is moving through the GI tract, all of that is not totally mature until certain points. So gastric acidity doesn't even reach that until about 2 to 3 years of age of that an adult. They're born with alkalinity in their stomachs. And so it's not surprising we get a lot of kids with spitting up things and spitting up formula and stuff. Breastfed is emptied much faster into the intestine than formula fed. So kids that are formula fed tend to spit up a little bit more. Now we give ranitidine liquid to those that have gastric emptying issues or reflux type issues, etc. So it's very interesting. And I actually didn't know that kids were born with alkalinity. So it was very interesting. If you give something IM or sub-Q, it depends. Is your baby sick? Is your child sick? Is their temperature cold? So that's going to affect how the medicine's going to perfuse through the skin. do they have a compromised cardiac, respiratory? So that all will be dependent on that. If you give it IV, we know it's going to go IV directly into the vein, so that's not as much of a worry. But if you're going to give something topical, we have to be really careful because the ratio to body surface area to body mass is a lot greater than adults. So what that means is that if you give a topical medicine, say a child has eczema and you're putting a steroid, you have to make sure you apply a very thin layer because it's more porous and it's going to absorb much more quickly than it would with adults. So now we're talking about distribution. How is it distributed? Remember, babies' bodies are and organs are more immature and they're developing at that time. So there is a risk of toxicity, especially in the first year of life, because there's different blood flow to the tissues. So you have to be careful when you're giving these medications. So the first year of life, we really try to avoid any medications in the child, which is a lot different from years ago. When a 6-month-old had a cold, we would give them Robitussin over the counter and stuff, but now it's not recommended to give anything. But just a little on the side, Benadryl is the drug that's been the most studied in kids, and it's a very safe medication to give to kids. So you may encounter that at this time. All right, so body fluid composition, tissue, protein binding is decreased. So, okay, remember back in the pharmacokinetics, we talk about like protein binding sites. So some drugs have to bind to the protein to get through into the tissues to work, right? Just to be distributed out. Well, infants and kids, neonates and infants don't have as many protein binding sites. So sometimes the medications, they can end up with toxicity because it's building up, because it's not able to get through to do that distributing, that second part of the pharmacokinetic. So you have to be careful with that. Also, if someone has hyperbilirubinemia, you know, the kids that go under the lights because their bilirubin is built up, bilirubin attaches to protein sites. So if you give medication, you have to take that in consideration too, that they really don't have enough protein binding capability if those drugs need to bind to protein, whatever you're giving. Another thing to be careful of is the blood-brain barrier. It's not immature like adults are, so you have to be careful of that. So the pharmacokinetic part, the metabolism portion, now it's being metabolized. So it's absorbed however you're giving it, and then it's distributed to the tissues of where it's supposed to go. Now it needs to metabolize. And remember, most drugs are metabolized in the liver. But remember that kids, with most kids, infants, neonates, the liver is still immature. And they have a higher metabolic rate. So remember, the liver's immature. So it's not going to, maybe not metabolize that the way that it would as a young adult would. And then excretion, remember, it's excreted then through the kidney. It needs to be filtered. Well, the kidneys are immature at that point. So they have decreased renal blood flow, decreased glomerular filtration rate, renal tubular function. So if you remember pathophysiology, the glomerular filter and the renal tubules, tubes, they are the ones that are responsible for excreting and keeping what the body needs and what it needs to excrete, and it needs to do it at a certain rate, like a fine oiled machine, and it is decreased because the kidneys are just immature at this point. Let's go to pharmacodynamics. Remember, that has to do with how the drug has an effect on the body. So this, I just want to give you one example, is that which I did talk about before. So when you're applying a topical on a child's skin, how will you apply it? Well, you're going to apply it very thin layer because we want to make sure that the effect it has on the body doesn't become toxic. You're always going to monitor for effects and adverse reactions. How are you going to determine what dose they get? Most or all pediatric drug dosing is by calculations, by weight, which is in kilograms. You have to always consider their developmental, cognitive differences. So differentiating developmental from chronologic age. They could be 8, but yet have a development of a 3-year-old. So you have to keep that in mind. As well as when you're giving it, you have to make sure that you're involving the family, and depending on the age will depend on how you're going to talk to the child and give the medication, because children, remember, their brains are immature, they're growing, and so they'll be scared of getting a shot. But it depends. If you're giving an infant a shot, will be different than giving a 2-year-old or a 6-year-old a shot. So for an example, if you have a preschooler and they're scared, which most of them would be, maybe you can have like a syringe without the needle on it and have them pretend to give the shot to a doll. So then they'll feel better and be like, oh, see, the baby did okay, and that kind of thing. And some of you I'm talking to maybe have had exposure in pediatrics. I don't know. All right, so teaching's directed towards the family and the patients, because when you're dealing with pediatrics, they're a minor. They don't understand. They don't have the reasoning skills. So it needs to be towards the family. You need to make the parents feel better about it too. I used to work in pediatrics, and there was nothing more scary to the parent than saying, we need to start an IV on your infant, and we would take them into a different room and use a papoose board. Well, how scary is that to a parent? So it really involves a lot of education, saying, okay, well, your child's really dehydrated, and we need to have them stay still for the safety of your child, so we make sure we get this IV in the first time, etc. Also, remember, babies can't talk, so sometimes it's difficult to assess for side effects. So are they crying more than usual, etc. I'm not going to repeat a lot of these because I know you guys know that developmental age, culture effect, all of that has an implication in that, because now we're talking about nursing implications. What are we going to watch for? All right. I'm not going to go through this either because I know this is very easy for you guys to read and self-explanatory, which I hit on the most important thing. So adolescents, are different. A lot of adolescents are already to grown adults' height and weight. They also have a different developmental stage than kids do, so we have to keep that in mind. When you're talking to adults, maybe talking to teenagers, they may not want the parents in the room, which is okay for doing physical exams and things like that. That's when you need to talk to them like they're an adult. That's when they're learning how to take care of themselves and do some more prevention. Are they going through puberty? So there's a lot of things to consider. Are they in high school? You need to talk about drugs and smoking. The best way to do physical exams on any age is they use the Denver Developmental Screening. If you feel like, you can Google it and try to find them. But basically, when this child goes in for a physical, they bring out the Denver Developmental. It's probably on the internet. It's on the electronic health record now. And they'll say, okay, can you stack 4 blocks? Can you do this? Can you do that? So, when they're an adolescent, you're also looking at what is the most common type of accidents that happen in teenagers. Is it, once they're driving, is it car accidents, suicide? And so you're going to do a lot of primary prevention teaching with the adolescents. So the nursing process, I'm not going to go through this, so you can read this, but this would be something that you would do if you're going to write a care plan, because just going through all of this, learning about age, weight, and height, their age, this stuff is really important for each age group because they're still growing. So it needs to be updated every time they come in. So we got the nursing diagnosis here, and then we got planning, which we talked about. And then just an example, what if a teenager keeps forgetting his Adderall at school? So how are we going to deal with that? What would be the best thing? So let's try to think out of the box. So he keeps forgetting his Adderall at school. probably already has permission to take it. So the best thing to actually do to make it easy is to have the pharmacy divide up his pills into 2 separate prescription bottles. That way he doesn't have to worry about forgetting it. He'll have one at school and he'll have one at home. I can't say there's one wrong way or one right way to do it, but thinking of the easiest way for the child so you don't forget, keep one there, keep one here. It's no different than, like, say you have divorced parents and you take medication. Keep one at mom's, keep one at dad's. Going back to that, you have to remember that this is a teenager, and so they're old enough. Now, I'm not talking about developmentally delayed. I'm talking about teenagers at normal developmental level. They're able to manage taking their Adderall at school. This is just helping them, problem solve in an easiest way to go through that. And then evaluation, you're going to make sure that they're doing okay. You're going to make sure that they're tolerating the medications. You'll talk to them. You'll talk to the parents, possibly. So here's some practice questions. A 6-year-old does not like the taste of medicine. How will you best help this child to take the medicine? So 6 years old, does not like the taste. So a 6-year-old can tell you he doesn't like the taste of the medicine, right? And they will be able to fight you basically on it. And so what are you going to do? Are you going to wait for the parents to arrive? Well, I hope the parents are already there when you're going to deal with this. Are you going to restrain the child? Probably not a 6-year-old. Are you going to tell the child to swallow it quickly? Or are you going to offer a choice of drink afterwards? So reality is there's no, beating around the bush with this. The child knows, we know that the child needs to take the medicine for the betterment of the child, right? So swallowing it quickly, that could be an answer. Offering a choice of drink afterwards might be a better answer because they have to take it. Maybe they don't know how to swallow quickly or don't understand what that means at this point. So I think D, you would offer a choice of drink afterwards. And that way it would put the child in control to say, hey, what would you like? I have orange juice, I have 7-Up, or cranberry juice. What would you like? Because when we give that, it's kind of like having a reward afterwards. A toddler requires an oral medication. It's most appropriate for the nurse to administer the oral medication. How? So a toddler, so we're thinking like age 2 to 3. So in a nipple, dipped in a pacifier, via an oral syringe, or mixed with formula in a bottle. So a toddler should not be on formula anymore and not use a bottle. So that takes out A and D. It wouldn't make sense in a pacifier because how could you would dip it in a pacifier, but that probably is not the accurate amount that they're supposed to have. And so that's not a good answer. An oral syringe is the best answer. So most kids at that age or even younger will take medications with the oral syringe. And what are drug calculations based on? So there's more than one answer here. The answer is age, because that's going to matter, right? Because we have to do the drug calculations, and their height and their weight. Some drugs are given based on body surface area, especially more potent drugs. But most drugs are based on weight. And so, yes, age trickles down to weight. So really the most important is weight. All three of these are consideration, things to take into consideration, but weight is the most important. All right, and that's it.